there's not an exact timeline, but
Yeah.
I guess the first things I started putting together were in about 2010, and moved out to Kenya in 2012. Ended up throwing most of them away several times because none of them worked in the way, or certainly didn't work in the hands of the people they were intended for. So I had things that worked in my hands. That was a big learning for me. As an ophthalmologist, I could make something work. That was very different to having a lay person be able to do it who had no health experience. And that's what I was aiming for. So it was really by the end of 2014 that we had the first really viable prototypes. And it was when we started embedding them in a system that we started getting the real value. So the first time we did that was when I was working with a fantastic ophthalmologist who has been part of our team ever since, called Dr. Rono, who has established a hospital that serves a population of around 1.5 million people in Kenya. And he was saying, look, in the schools around me, there are children who I know can't see because I've been sending a team to go and assess them. And normally around 5% of the children in the school will have an eye problem. But the problem is I can't afford to keep sending my nurses when my clinic is so busy, and 95% of the children that they examine are okay. So I've had to stop the program. And he said, I've seen what you're doing with these smartphones. Is there something we could do together? So we sat down in a coffee shop and we came up with this concept that we could train teachers to do the vision screening. So they would examine 100% of them to find the 5% with the problem. And then the team from the hospital would just see the 5%. So you basically get 20 times efficiency for their effort. And we built the whole thing out. We added in automated messaging. So when a child had been found with a vision problem, it would send a message to the parents. We also built in a referral notification to the hospital, so the hospital could start to manage the capacity. So you could start to tailor how quickly do you screen, knowing how many people you can manage. And then we started building in behavioral change things, because we realized in the same way when I was a kid and no one understood that I couldn't see and I couldn't articulate it, when the teacher would do the vision test on a smartphone, it would show them what the child could see by creating a split screen of normal vision versus a level of blur based on the vision test just done. So suddenly they were seeing what the child could see, and that would just be a penny drop moment for them. So all of these layers we started to put on, because we realized if you just identify somebody, you haven't solved the problem. And if you tell the hospital that this person is coming, you still haven't solved the problem. If that person goes and gets treatment that works, then you've solved the problem. So all of these layers and different steps you have to take care of. And so we started to build all of that. And once it was working, we ran it as a randomized controlled trial in which about 21,000 children were screened by 25 teachers. And they did that in 9 days. And they found 900 children with vision impairment when doing that.
Wow.
So that became our first real proof point of a systems approach to this that was working. And ever since then, we've expanded on that to add in more and more functionality. So going from, in that program, the baseline around 1 in 5 children found would make it to the hospital. When we added in the messaging and the vision simulator, half the children made it, but then it still meant half didn't. So we added in this middle layer, this triage layer, where after so many schools had been examined, a team would go and set up a temporary camp near the schools, and then people would come there. So they didn't have to travel so far, kind of going back to that experience that distances are really hard to cover if you have minimal resources. So bring the services to the people. In doing that, we got over 85% coming. So this kind of continuous improvement of taking down the barriers. And then we started applying the same methodology in different places. So the next place we did it in was in Botswana, where they were getting around 10% of adherence to referral to the hospital. So 1 in 10 people referred turned up. And when we put this whole mechanism in, we got it up to 96%. And the data was so compelling that the government made a commitment to basically adopt this nationally and screen and treat every single school child in the country. So now working with the Ministry of Health and the Ministry of Education to roll this out nationwide. And then we did a similar process in India. But in India, we went one step further and we wanted to see, for those who'd received treatment, what happened to them afterwards, because it's an assumption that if you've got treatment, the treatment's worked. And this trial question was specifically for glasses only. We didn't look at wider things. But there we found out that half of the children given glasses at 3 months weren't wearing them. And so we started to say, well, why are they not wearing them? What are the social barriers and so on? And so we basically built out this impact pipeline, which starts with, of the population that you're aiming for, how many did you find? Because you don't always find everyone. They may not be there, or they may refuse, or so on. Of the ones that you find and you refer for services, how many make it? And so how many drop out? And then of those who make it, how many does it work for? And effectively, your impact calculation is how many people out of the base denominator actually get all the way to the end. And everyone that drops out is a barrier that the system needs to address. And what is it about the people that fall out versus the people that don't? And that started to address that question I had, which I said at the beginning, which was the thing that was troubling me was, who was I not seeing? Now I was here now, but who's not here? You know, it's easy to base your worldview on what you can see, which is ironic in the world of vision. But the question for me is always, what can you not see? And who can you not see? What's different about them? What barriers do you face if you're a rural woman who's not educated versus a man in the city who's got an education and finances? Like what's the disproportionate access to services? And so the data view started to really help us see that certain groups are disproportionately affected. And if you don't start directing your resources towards the most vulnerable, you'll never make the kind of impact you're aiming for. But if you don't see that, you can't respond to it. And so that's become our product, basically. It's the ability to equip partners with the ability to see their population and see what change they're making in it, and then respond to where the pipe is leaking.